Halo, Cak.
Ya, Prof. Ya, Prof.
Cak.
Iya, ini masih intro, nanti jam 4 pas saya mulai ya, Prof.
Oh iya.
Terletak di kawasan hijau kampus Universitas Indonesia, Rumah Sakit Universitas Indonesia hadir sebagai bentuk persembahan UI kepada masyarakat dalam memberikan layanan kesehatan. RSUI memiliki kemudahan akses melalui berbagai jalur transportasi. Dibangun dengan konsep Green Hospital, hadir untuk menjawab permasalahan di bidang pelayanan, tenaga kesehatan, sistem rujukan, serta pemanfaatan sumber daya. Menjadi bagian dari Academic Health System atau AHSUI, kolaborasi jejaring fasilitas kesehatan dan Fakultas Rumpun Ilmu Kesehatan Universitas Indonesia mewujudkan peningkatan kapasitas sumber daya serta menunjang tridharma perguruan tinggi. Memberikan pelayanan akuntabel, holistik, komprehensif, terintegrasi, multidisiplin, serta berkesinambungan antar tingkat pelayanan kesehatan didukung sistem informasi dan teknologi rumah sakit. Seluruh klien RSUI dikaji berdasarkan riwayat penyakit dahulu, keluarga, dan pola hidup. Dilakukan asuhan keperawatan oleh nurse dan pemeriksaan menyeluruh oleh dokter yang berorientasi pada pencegahan dan biopsikososiokultural. RSUI mendedikasikan fasilitas layanan maternal, kesehatan reproduksi, dan neonatal untuk mendukung penurunan angka kematian ibu dan bayi. Dengan perawatan terbaik bagi bayi baru lahir dan anak yang mengedepankan a traumatic care dan patient family center care. Memiliki layanan unggulan neurokardiovaskuler untuk kasus jantung, otak, dan pembuluh darah secara komprehensif dan dilengkapi cath lab by plan. Menerapkan sistem kegawat daruratan code stroke untuk penata laksanaan optimal pasien dalam hitungan menit. Kami menyediakan pelayanan minimal invasif dan komprehensif dalam satu klaster yang merupakan masa depan layanan kesehatan. Pusat Kesehatan Gigi dan Mulut yang lengkap dan mutakhir menyediakan layanan gigi pencegahan, umum, dan spesialistik. Pelayanan IGD dilakukan oleh tenaga dokter dan nurse profesional yang tersertifikasi. Kami memiliki 4 laboratorium komprehensif di dalam satu rumah sakit. Pengelolaan pasien melibatkan peran serta keluarga melalui konseling. Mewujudkan pendidikan interprofesional bagi calon dokter, dokter gigi, nurse, apoteker, kesehatan masyarakat, maupun tenaga kesehatan lainnya. Serta mengembangkan kolaborasi interprofesional dalam pelayanan, riset bidang kesehatan, serta pengabdian masyarakat. Community Health Center melayani upaya promotif dan preventif bagi individu, keluarga, dan komunitas. Kesinambungan pelayanan mulai dari perawatan sampai pasien pulang ke rumah dilakukan oleh tim home care multiprofesi. RSUI berkomitmen memberikan pelayanan kesehatan kepada individu, keluarga, komunitas, dan masyarakat yang efisien, berkesinambungan, berbasis bukti, serta mengikuti perkembangan zaman sesuai moto kami, we provide outstanding care.
Selamat sore semuanya. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Selamat sore para peserta webinar sekalian. Saya mengucapkan selamat datang dalam acara webinar series Interactive Course for General Practitioners I-Corps Rumah Sakit Universitas Indonesia 2020. Hari ini kita akan mengadakan guest lecture yaitu Funduscopy for GP, DI, and Beyond. Perkenalkan, nama saya Anissa Wicaksono. Saya adalah spesialis mata di Rumah Sakit Universitas Indonesia. Pada kesempatan kali ini akan bertindak sebagai moderator yang memandu jalannya webinar sore hari ini. Sebelum kita memulai acara, saya akan membacakan mekanisme dan tata tertib selama berlangsungnya webinar ini. Mungkin panitia boleh tolong ditampilkan. Oke, seminar kita pada sore hari ini terdiri dari 2 topik yang masing-masing akan berlangsung selama 30 menit. Mungkin akan agak sedikit berbeda dengan seri sebelumnya. Untuk Q&A pada seri hari ini akan kita kumpulkan di akhir, jadi dari narasumber akan memaparkan materi dulu masing-masing selama 30 menit, baru di akhir kita akan mengumpulkan Q&A-nya. Q&A bisa diketik di kolom Q&A di Zoom. Mohon maaf, ini ada sedikit kendala, jadi memang di YouTube belum bisa live, jadi mungkin teman-teman yang bergabung di Zoom bisa menuliskan Q&A-nya baik di chat maupun di Q&A. Dan di akhir dari series nanti akan ada link evaluasi yang bisa diisi oleh peserta untuk mendapatkan sertifikat. Saya akan mengingatkan bahwa peserta yang memberikan komentar mengandung unsur sara, provokatif, ujaran kebencian, atau mengiklankan sesuatu produk atau acara lain akan dikeluarkan dari acara webinar ini. Kemudian peserta dilarang untuk merekam materi yang dibawakan. Bila memang ingin menyaksikan kembali serial-serial sebelumnya ataupun serial ini, dapat mengakses website di rs.ui.ac.id/webinar atau di kanal YouTube RSUI. Oke, mungkin kita akan segera memulai. Saya ingin melanjutkan langsung ke acara berikutnya tanpa menunda-nunda lagi. Kita akan ada 2 presentasi. Presentasi yang pertama akan disampaikan oleh Profesor Paul Healey. Boleh ditampilkan kurikulum vitae beliau. Okay. Professor Paul Raymond Healey, he graduated Bachelor Medical Science from University of New South Wales, and he finished his postgraduate as a Master of Medicine in Clinical Epidemiology from University of Sidney, and also Doctor of Philosophy in Medicine from the same university. He went for the ophthalmology fellow in Moorfields Hospital in London, and currently he is the clinical associate professor from the University of Sydney, also the director of glaucoma service from Westmead Hospital, Sydney, Australia. He is an outstanding researcher, has hundreds of publications, more than 170, if I'm not mistaken, publications in both ophthalmology and also in clinical epidemiology. Probably without further ado, I would like to ask Prof. Healey if you would like to share your screen and also probably turn on your video. Hi.
There you are. Good afternoon, everybody. Thank you very much for that kind introduction, Anissa. I presume you can see the slides on the screen?
Yes, I can see it.
Great. So this afternoon, I'm going to give you a little bit of background about glaucoma in Indonesia. But what I'm going to say about glaucoma, I'm sure you'll realize, applies to many other diseases, not just eye diseases, but other chronic diseases which you need to manage. And the reason for giving this talk is not just to give you some important information and to upskill you in diagnosis of glaucoma and other eye diseases. It's also to bring to your attention some major changes that have been happening in Indonesia over the last couple of decades, and which are going to quite radically change the kind of diseases and the kind of patients you're going to be caring for in the future. So what I'm going to present with glaucoma is 2 present challenges and 1 future trend. The first challenge is the better understanding of the importance of glaucoma in Indonesia, and much of this talk will cover that topic. But the second is more general. It's a better understanding of the challenge of chronic disease management, which is a challenge for doctors everywhere in the world, and which requires a new way of thinking about the way we manage chronic disease. And much of the problem we have with glaucoma relates to the way we understand the management of diseases and the way certain diseases seem to slip through the net and end up presenting late with very severe symptoms. The challenge is going to be a better understanding of our patients, because we're not going to be able to achieve the paradigm shift in disease management unless we understand our patients better, unless our patients understand us and our health system better. So the first question to ask, of course, is glaucoma a problem in Indonesia? I'm sure when you think back to the eye conditions you frequently see, glaucoma will not seem to be a major issue. Trauma, I'm sure, infection, cataract, but not glaucoma, and probably not other diseases which you might think are seen in elderly Caucasian populations, such as macular degeneration. Well, there are two aspects to whether a disease is a significant public health problem. Firstly, it's the prevalence of the disease, but secondly, the impact. And I'm going to deal with those two. The prevalence of glaucoma changes very dramatically with age. And this is probably the most important take-home message with this disease. This is a paper we published many, many years ago from the Blue Mountains Eye Study, which was centered just outside Sydney. And what you can see there is the prevalence of open-angle glaucoma, the most common type of glaucoma, and age. And indeed, you can see in a population under 60, the prevalence is extremely low, but it increases exponentially with age. And of course, what that means is that the older the group of patients you're going to be looking after, the more likely they are to have this important disease. And because of that, glaucoma is actually the second most common cause of blindness worldwide, and certainly the number one cause of treatable but irreversible blindness. So, does Indonesia have an elderly population? Well, this is what the population looked like in Australia in 1990 when we did the Blue Mountains Eye Study. And what you can see is that there's this bulge between 15 and 44. We call it the baby boomers. After the Second World War, there was an outbreak of procreation, and we had a sudden increase in the Australian population. And of course, that cohort is now moving through the ranks. What did Indonesia look like at the same time? Well, quite different. Most Indonesians were children or young people. This doesn't surprise you. In 1994, which was the closest date I could get this data from Indonesia, as I'm sure you realize, the life expectancy was relatively low. Indonesia was overcoming a lot of the major illnesses that caused a lot of infant and child mortality. And so the younger ages were booming. Now, in Australia today, the demographic has changed. That bulge has moved upwards. And what you can see is that there are now many, many older people in Australia over the age of 65. In Indonesia, the same thing has happened. Again, not quite as much as Australia. You can see that bulge moving up, but it hasn't quite reached the heights that it has in Australia. But if we look at Indonesia in 2040, we see that the demographics are remarkably similar. By 2040, there will be a substantial percentage of the population over the age of 65, in the order of 10 to 15%. And given the population of Indonesia, which is forecast to be some 318 million people by that time, that's a very large number of people. So you can immediately see that any disease that has increasing prevalence with age, particularly if it increases rapidly, is going to be a big problem in the future, even though you may not see it at all right now. If we look at the number of people that have glaucoma in that population, we look back at Australia in 1990, about 500,000 people had glaucoma, which is certainly important in a population of some 20 odd million. Indonesia, back in 2020, it's about 1 million people. Now, that's a relatively small proportion of the 273 million people in Australia, but it's certainly not minuscule. It's certainly something that deserves some consideration. If we look what's going to happen in another 20 years, those numbers are going to double, which is what you'd expect for any of these exponentially increasing diseases over the course of 20 years. So as time goes on, these diseases become more and more prevalent and therefore more and more important. What's also important to realise is that about 500,000 of those people are young, between 40 and 60 years of age, when they're still working. And that's very important when we look at the next impact about glaucoma, which is so important, which is the impact of the disease. Think for a moment of somebody back in 2014. On the left, you have somebody who has some mild cataract. And on the right, you have somebody with glaucoma. And that visual field test result you can see showing that blind spot over on the right-hand side, which of course we all have, but that rather worrying small black area very close to the center of vision, which is the only sign of that person's disease. What happens now? What happens later on after treatment? So at the time of 2014, the visual acuity in the patient with the cataract was mildly reduced. They were still quite functional. What happens now? Well, the cataracts got worse. But they have their cataract operation, their vision is restored, and really that time that was lost between 2014 and now as the vision deteriorated didn't make a big difference, because after the operation, they're back to seeing normally again and will see well for the rest of their life. What happened to that glaucoma patient in the same time period? Well, their vision was actually better in 2014. They didn't know they had anything wrong with them at all. Their vision dropped to hand movements, just as it did in the cataract patient. But after their treatment, nothing happened. Why? Because the vision loss was caused by neuroretinal degeneration and a loss of the visual field, and that's an irreversible damage. So that patient who's presenting to your surgery with hand movements vision is, on one hand, for the cataract, not suffered at all by having the diagnosis missed, and will go on to have a successful treatment. But for your glaucoma patient, the vision will be irretrievably damaged. And of course, people with glaucoma also get cataract. So if that patient presented you with that white cataract, you and we would look at the patient and think, well, the vision's poor, the cataract is dense, we'll do the operation. But for that patient on the right, not only have you not restored his vision, but you spent all the money and resources on a cataract operation unnecessarily. So the problem with glaucoma in particular is that although it only has a modest prevalence, it has a very high impact. It can cause complete, absolute bilateral blindness. And so you see 500,000 people between age 40 and 60 with this disease is a very serious problem, because people who are bilaterally blind can't work, can't support the family, can't pay their taxes. And there's many, many flow-on effects for the health and well-being of people around them. What's worse, in glaucoma, treatment's well established. Now, it's only preventative. We can't cure the disease, but something as simple as an eye drop, which costs a few cents, can reduce the rate and the risk of disease progression by at least 50%. So while disease progression is irreversible, it's treatable and preventable. Furthermore, finding glaucoma cases is relatively straightforward. Family history is a very strong risk factor, and particularly family history of glaucoma associated with blindness, and intraocular pressure, which is certainly usually easily measured by an optometrist, and certainly if you have the right kit, you can do it in the general practice, is a very, very strong risk factor for treatment. And clinical evaluation, a simple evaluation of the optic disc with the ophthalmoscope, as Prof Vicky will describe, can detect glaucoma very easily. And a visual field test can very accurately show visual disability. So the question then is, why are the clinics in Indonesia and many of the clinics in Australia full of blind people? Why are we missing this disease? This is the challenge of chronic disease management, and it's to do with the way the health system works. You all know this. You're taught it at medical school. A person has a symptom. That symptom is a concern to them. So they come to see you. They say, "Doc, my neck's been hurting. At the end of the day, it's getting worse. I'm getting tingling in my fingers. What's going on?" So you'll do an examination, you'll do an investigation, and you'll come to a diagnosis. You will then prescribe some treatment or perform some treatment on the patient. And the patient will accept that treatment in trust with you, and he or she will observe his or her symptoms and will rate that treatment based on the symptomatology. So you give them a treatment, the headaches disappear, and they're happy, and they go home, and that's the end of the episode. But that, of course, has some key cultural presumptions in it. Firstly, it's that the patient seeks your attention. So clearly, as I'm sure you know, very poorly educated patients who've been brought up without the normal social connections may not seek attention if they have a problem. The patient is also doesn't feel they're part of the decision-making measures. There's a huge intellectual asymmetry between most patients and their doctors. So they come to you, they don't know anything about the disease, they don't really want to know anything, they just want to know what to do to make it better. And of course, what that means is they really think it's your problem to fix them. They come to you, please fix it, doc. And on the doctor side, of course, it's reliant on us being diligent, making an accurate diagnosis, choosing the correct treatment, and choosing a treatment to make the patient better. But imagine this scenario. What if the disease and the person has no symptoms at all? What if the treatment doesn't make the patient feel better? What if the treatment actually makes the patient feel worse? And then what if the patient's asked to continue that treatment indefinitely? Well, that's glaucoma. And of course, if you think about it, that's also hypertension, that's also diabetes. In fact, any of these chronic diseases where at the time you make the diagnosis, the patient's feeling fine, and you're asking them to spend time and money taking some sort of treatment which doesn't make them feel any better in order to prevent something that they don't really understand which might happen in the future. Let's sit back and look at glaucoma from 1,000 feet. And again, we can apply this to any other chronic disease. If you imagine a graph which on the x-axis you have the age of the patient. On the y-axis you have some measure of state of disease. In this case, it's the amount of nerve tissue left in the eye. Over time, that disease gets slowly worse, but for a long time, there's no symptoms for the patient, and there's no way that we can pick the disease up. At some stage during the treatment, we see the disease can be detected, and we have an opportunity to treat. And if we don't treat, things get worse and worse until some severe symptom develops, which in glaucoma, of course, is blindness. The fact of the matter for most diseases is that the period between when you could have first picked the disease up and when the patient becomes blind or they have their stroke or their heart attack is decades. So as long as we look for it, we should be able to pick up the disease. And what that means is early diagnosis doesn't mean early disease. Most doctors would regard early glaucoma as mild damage. This is a patient we saw in the Blue Mountains eye study who's lost half of their visual field. If you look at that field of vision test on the right, the bottom half is totally black. And yet they were diagnosed for the first time. So while that is what we call severe disease, the patient was relatively asymptomatic. And therefore diagnosing this patient during the study was a great benefit for them. It allowed them to receive treatment. So the problem with trying to find these diseases when people are asymptomatic, is that the disease is detected by screening. There are fewer no symptoms, so the patient doesn't have an incentive to seek care. And we know that. That's why when a patient comes in with a cough or a cold, we measure their blood pressure. Not because we necessarily think it's related, but because if they've got hypertension, we're going to pick it up at that episode. Because there's no cure, because treatment prevents progression, there's no outcome measure for the patient to assess. So there's no incentive for them to take the treatment. And also regular follow-ups required. That's expensive, both in terms of time and money. And because there's no resolution, there's a strong incentive for denial of the disease. So it's very likely that the patient, after perhaps a few follow-up visits, will think, well, this is just a waste of time and money. It's not doing me any good. I don't feel better. I'm going to stop the medication and go away. So clearly, we're not going to be able to treat glaucoma nor any other chronic disease with this paradigm. We need a new paradigm which somehow has our patients understanding what we need to do for them and have us understanding what we need to do for our patients. And it's based on a number of key things. The first is education. Understanding of preventative care, this whole idea of preventing something bad happening in the future, is really, really critical, because it's the knowledge of that bad outcome. It's knowing that you might go blind. That's incentive for you to go to your doctor and say, listen, even though my family's gone blind, can you check me out and can you do something to stop it happening? Participation is critical as well. If a patient thinks the problem is yours and they're not feeling better, they're not going to participate. They're not going to take their treatment because they don't feel like they own it. So the new paradigm is for doctors and patients to make treatment decisions together. I realize there's a big asymmetry of knowledge, but we're well trained as doctors to be able to explain things in simple terms to patients, and making them feel like they're part of the decision making and starting to give advice rather than prescribing treatment does empower the patient to feel like they're making a contribution. And also, of course, if they're not complying, you can say, well, listen, you made that decision, remember? You decided you were going to take that tablet or take those eye drops. So ownership of treatment is an incentive to take it. And thirdly, cooperation, of course. If a doctor and a patient are together responsible for the care plan, that is an incentive for the patient to participate. Sharing the responsibility improves adherence to treatment and follow-up. There's good evidence around the world for that happening. The challenge, of course, is getting the patient to realise that this is their problem too, that they need to participate in. And of course, getting them to prioritise that against all the other important things which may be affecting their life day to day, which is, where is the next meal going to come from? Where am I going to find work? So there are, as you'd expect, a number of barriers to implementing this paradigm. Cultural ones are the most important. As I'm sure you're seeing during the coronavirus pandemic, as we are, the biggest problem in public health is not the medicine, it's the culture. It's getting people to change their behaviour. So changing the doctor and patient roles is very, very difficult. It takes generations. But we need to start in order to get our patients to follow. Ownership of medical problems can be very difficult. Understanding of risk is probably one of the most important things. I think all school children should be taught about risk. Most people are risk averse because they are fearful, or they're risk takers because they don't think of the risk. People don't go and think of the chances of hurting themselves when they go bungee jumping. They either are afraid of the idea and don't do it, or don't think about the risk and do it. Having people, as part of their schooling, understand about risk and probability will help them make a decision which may help them in the future. There are structural problems. For example, if you prescribe a medication, unless you have got feedback about whether the patient is filling the prescription, you don't know whether they're taking it. Our clinics are full of people we're seeing every day. How do we track the people we don't see? We often lose them. If a patient doesn't come, we try and contact them, they still don't come. We're too busy looking after the patients under our care to follow them up. So we need reminder systems, we need action plans, and we need feedback from health systems to tell us about patients' participation in their management. And lastly, we need to look at the financial costs. Governments need to look at cost subsidisation for patients so that we can treat patients on clinical need rather than on their ability to pay. So the keys to overcoming barriers are the doctor-patient relationship, as you'd imagine. Trust and education are key. And when the doctor and the patient are thinking along the same lines, that's called concordance. The patient-society relationship is also very important, because making sure that health is promoted as an important measure of societal function is very important. And understanding of risk-benefit, not just amongst patients and doctors, but amongst politicians and bureaucrats, is very important. And of course, that's all about decision analysis. How do we decide to allocate the resources to these health problems? How do we deal with these health problems? And lastly, of course, is the doctor's relationship with society. The idea that the doctor's role is not just on the patients who are in their clinic, but in public health generally, and the important advocacy role we play for standing up for our patients when they're unable to stand up for themselves. And key to that, of course, is understanding the need to change and the need for change. Because if we keep doing what we've been doing with symptomatic management of medicine, we're going to miss all the diseases which are the scourge of the Western world, and which in time, as infection and trauma are overcome, going to be the main problem for Indonesia as well. So in conclusion, glaucoma is an important disease in Indonesia because it has a high impact. It causes very severe blindness, and it causes that in a substantial number of younger people. The prevalence will keep growing. It will grow exponentially. And as refractive error gets fixed, as cataracts gets operated on, as infection and trauma is prevented by better hygiene, by better working conditions, they'll become less common. And glaucoma and the other chronic age-related eye diseases will become the major eye diseases that you see in your clinics. The greatest management challenge for glaucoma at present is that the same of all chronic diseases. Our health system is really based on 19th century approaches to symptomatic treatment. And while that works really well for an infection or trauma, it doesn't work well for these diseases. We and our patients are poorly educated in modern preventative healthcare. And if we master this, the advantage is that we have plenty of time. We have those decades to actually prevent blindness, to prevent stroke, to prevent heart attack, and to prevent the many scourges of diabetes related to this and other chronic diseases. In order to overcome these health challenges, we need a new trend of cultural change so that everyone in Indonesia understands risk. They understand the idea about prevention, about health ownership, about partnering with their doctors. And the only way to achieve this, of course, is with better communication. That's a big challenge in such a disparate community as Indonesia. But, you know, you're lucky because the 21st century, there's a communication revolution, right? We're struggling to reach people in these little villages. I bet they've got a mobile phone, right? I bet Facebook can reach them, even if you can't. So as daunting as it sounds, many of our patients actually already have the means to communicate with you. They have high-tech computers sitting in their pockets, which they're using all the time. The moment they're using it to, you know, look at Facebook and see what their friends are doing, rather than learning important health lessons. But with that capacity, certainly it must be within the grasp of a vibrant, developing society such as Indonesia to actually utilize that technology to bring these paradigm shifts to improve the health of everyone. Thank you very much.
Thank you very much, Healey, for the presentations that probably give us another perspective and also a reminder of how we can approach chronic diseases and probably how to see chronic disease in different perspectives, new paradigm probably. And I'm sorry, I'm going to continue this in bahasa, Prof. Healey.
Sure.
Jadi kita akan melanjutkan, kita akan menunda dulu untuk pertanyaannya. Jadi para peserta bisa mungkin kalau ada pertanyaan bisa mulai menuliskan dulu di Q&A, nanti akan kita rangkum. Tapi kita akan melanjutkan dulu presentasi. Tadi kalau Prof. Healey sudah memberikan perspektif yang mungkin garis besar mengenai pentingnya funduskopi dan juga pencegahan dari penyakit-penyakit kronis, kita akan mungkin lebih spesifik lagi sekarang. Presentasinya akan disampaikan oleh Prof. Widya Artini. Mungkin Pak Widya boleh saya bacakan dulu CV Prof. Widya Artini. Profesor Dokter Widya Artini, spesialis mata konsultan. Beliau beliau lulusan dari FKUI, baik dari dokternya maupun spesialis dan juga doktoral yang diselesaikan di tahun 2007. Beliau menjadi guru besar di tahun 2019. Saat ini beliau bekerja di Rumah Sakit Cipto Mangunkusumo, Departemen Ilmu Kesehatan Mata, FKUI Sp.M. Beliau sudah memiliki banyak sekali penghargaan dan juga penelitian dan publikasi di bidang mata, terutama di bagian glaukoma. Tanpa menunda lagi, saya persilahkan Prof. Ike untuk memulai presentasinya. Masih ke-mute, Prof. Ike, mohon maaf. Mungkin bisa share screen dulu, Prof.
Share screen. Oke.
Ya. Oke.
Share screen kok nggak bisa ya? Bentar dulu ya.
Ya.
Ini bisa ya?
Ini muncul tapi kayaknya desktopnya Prof. Ike. Mungkin bisa share screen-nya dari yang PPT atau keynote-nya ya, Prof.
Ya, sebentar ya.
Ya.
Keluarnya gimana? Keluarnya. Bentar.
Tadi pas pertama sudah masuk, Prof.
Iya, makanya kalau udah keluar lagi susah juga nih.
Kembali ke Zoom-nya dulu, Prof. Kemudian ada share screen di bawah.
Iya, sebentar, Bu.
Zoom-nya tadi mana, Bu? Di desktop-nya lagi, Bu.
Sebentar ya. Kamu tuh gimana sih? Kamu nggak bisa kan? Ini kan Zoom.
Ini. New share.
Ya, new share, betul. Kemudian pilihnya yang, ya, sudah, Prof. Tinggal di play saja, Prof.
Atau
Slideshow, ya.
Slideshow, ya.
Baik, ini bisa kelihatan?
Oke. Bisa, sudah, Prof. Silahkan, Prof. Ika.
Kasih maaf nih ya, agak sedikit. Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, salam sehat untuk kita semua. Saya sebenarnya hanya singkat saja untuk menjelaskan bagaimana pemeriksaan funduskopi direct untuk screening pada sore hari ini. Mungkin berbeda dari paparan dari Prof. Healey, ya. Jadi lebih singkat, lebih mudah mungkin karena ini adalah untuk dokter umum. Mudah-mudahan agak lebih dimengerti. Ya, jadi penggunaan dari funduskopi bagi screening tentunya sudah dipahami oleh seluruh dokter umum. Ya, jadi penggunaan funduskopi ini memang harus dipahami oleh dokter umum guna untuk memperlihatkan bahwa seperti misalkan retinopati, karena pada umumnya penderita yang memiliki suatu penyakit diabetes tentunya harus kita melihat bagaimana keadaan retinanya. Nah, apabila dia menderita penyakit diabetes lebih dari 5 tahun, kita harus melihat retinanya. Pada umumnya penderita itu memiliki retinopati diabetika. Oleh karena itu pentingnya dokter umum memeriksakan retinanya dengan menggunakan funduskopi dan bagaimana keadaan retina tersebut. Ini adalah gambaran retinopati diabetika. Kemudian apabila dia mempunyai hipertensi, retinopati hipertensi, dan apabila mempunyai kekentalan darah, tentunya kita akan dapat melihat oklusi penta retina sentralis. Nah, juga demikian pula apabila pasien yang menderita miopia tinggi, misalkan mata yang minus, dokter umum dapat melihat dengan menggunakan funduskopi adanya ablasio retina. Nah, bagaimana dengan glaukoma itu sendiri? Baik, nah di sini diperlihatkan oleh Dr. Ratnanisi ya, yang di Jawa Barat yang menunjukkan hanya 7% dokter umum yang melakukan screening funduskopi terhadap pasien diabetes mellitus tersebut. Jadi pentingnya pasien-pasien yang diabetes mellitus itu dilakukan pemeriksaan diabetes. Contohnya adalah suatu penelitian dilakukan di RSCM, di mana pasien diabetes mellitus yang dilakukan di RSCM itu sebanyak 28% yang menderita diabetes retinopati yang cukup berat dan 15% harus dilakukan tindakan bedah dan ternyata mengalami kebutaan permanen di situ. Jadi tolong diperhatikan oleh teman-teman semuanya bahwa pentingnya melakukan suatu pemeriksaan funduskopi pada pasien diabetes mellitus, terutama apabila pasien itu telah menderita diabetes mellitus di atas 5 tahun. Nah, bagaimana kasus glaukoma di Indonesia? Glaukoma kita ketahui dari paparan Prof. Healey yang mengatakan bahwa di Indonesia ternyata merupakan kasus nomor 4 dari angka kebutaan yang terjadi sebanyak 3%. Ya, dari angka kebutaan yang telah dilakukan survei oleh Perdami sebanyak 3% tersebut, glaukoma mempunyai kontribusi nomor 4 setelah katarak. Tentunya katarak adalah yang terbanyak 81%, kemudian disertai oleh glaukoma kemudian oleh kelainan segmen posterior dan kemudian oleh glaukoma. Hal ini disebabkan karena tentunya tadi telah dikatakan populasi yang semakin banyak, jumlah angka life expectancy yang juga semakin panjang, dan outpatient klinik yang datang ke rumah sakit karena adanya BPJS juga membawa pasien-pasien dan pasien kasus glaukoma yang semakin banyak. Ini adalah data di bawah ini, data ini ya memperlihatkan dari tahun 2015 jumlahnya hanya 65.000, 2017 tampak di sini jumlahnya semakin banyak yang datang ke rumah sakit. Nah, glaukoma itu adalah sekumpulan penyakit saraf mata yang merupakan dan menyebabkan kematian sel ganglion adalah yang secara klinis menyebabkan penipisan serabut saraf retina dan hilangnya neuroretina rim dan optic disc, dan diikuti oleh rusaknya lapang pandang yang berkorespon dengan kelainan struktur dari saraf mata tersebut. Dan tekanan bola mata merupakan suatu faktor risiko yang utama. Adapun tanda dan gejala yaitu kelainan strukturnya yang berupa serabut saraf retina tersebut, kematian sel ganglion retina, kerusakan akson, dan akhirnya menyebabkan coupling atau penggauan saraf optik tersebut, dan kelainan fungsi penglihatannya. Hal itu disebabkan adanya pada umumnya akibat kenaikan tekanan bola mata di atas 21 mm Hg. Pada umumnya normal dari tekanan bola mata adalah 10 sampai 21 mm Hg. Jadi teman-teman semua masih ingat ya 10 sampai 21 mm Hg. Nah, ini adalah patogenesisnya. Apabila kita melihat dari gambar pertama di sini, humor aqueous yang berada di dalam mata tersebut ya diproduksi oleh badan silier yang berada di belakang dari bilik mata belakang dan kemudian akan mengalir menuju ke depan lensa dan dialirkan menuju ke bilik mata depan dan akhirnya keluar melalui anyaman trabeculum. Nah, apabila pada ini glaukoma sudut tertutup, di mana terjadi blokade pupil, iris akan menutup saluran keluar dari anyaman trabeculum tersebut. Akibatnya terjadi penumpukan humor aqueous di belakang dari bilik mata belakang tersebut. Ya, dari bilik mata belakang tersebut. Nah, akibatnya tekanan bola mata akan meningkat sangat tinggi. Nah, sama juga dengan glaukoma sudut terbuka. Di sini yang terjadi adalah kerusakan dari keluarnya humor aqueous. Jadi anyaman trabeculum menjadi rusak di sini dan mengecil. Akibatnya aliran humor aqueous ini terjadi terhambat sehingga terjadi penumpukan atau cairan humor aqueous itu trap di dalam ataupun di depan dari bilik mata depan. Akibatnya tekanan bola mata di dalam ini meningkat dan menekan di anyaman dan menekan optik nerve. Dan ini adalah daerah yang sangat sensitif dan terjadi penggaungan dari optik nerve yang kita sebut adalah tadi akson dari neuroretinal atau sel ganglion tersebut atau optik nerve tersebut, ya. Ini yang menyebabkan kematian sel-sel saraf atau optik nerve tersebut. Ini adalah salah satu gambarnya, di mana optik nerve, saraf optik nerve yang normal, gambaran yang normal di sini, ini adalah kapnya, keluarnya pembuluh darah, arteri dan vena. Tampak di sini, ini adalah disnya, batas dari sklera, dan ini adalah jaringan yang sangat lemah, lamina cribosa, dengan tekanan yang sangat tinggi akan tertekan ya lamina cribbosanya karena ini adalah jaringan sangat lemah, dan ini adalah gambaran glaukomatosa ya, dan akibat tekanan yang sangat tinggi dan akan menggaung sedemikian rupa sehingga sel-sel ganglion tersebut yang berada di retina di sekitarnya akan mengalami kematiannya, dan akibatnya sel ganglion merupakan suatu badan ataupun saraf-saraf hantaran ataupun aliran listrik yang diterima untuk menghantarkan cahaya yang masuk dan untuk menghantarkan listrik untuk melihat kita yang akan dialirkan sampai ke otak akan mengakibatkan terhambat dan kita akhirnya tidak dapat melihat kembali dan akhirnya kita tidak menjadi kebutaan permanen. Ini adalah yang menjadi penyebab seseorang menjadi tidak dapat kembali normal, berbeda dengan katarak apabila dilakukan operasi katarak dan penglihatannya akan kembali normal. Tetapi pada glaukoma karena yang disebabkan adalah kelainan saraf akan sulit penglihatan itu dikembalikan ataupun dipulihkan kembali seperti sedia kala. Nah, ini adalah fungsi penglihatan seseorang di mana penglihatannya ini adalah penglihatan yang normal, kemudian dari penglihatan yang normal itu ini adalah early glaukoma menjadi mengecil, akhirnya semakin mengecil, akhirnya makin mengecil lagi seperti mengintip melalui lubang kunci. Nah, ini sering sekali tidak dirasakan oleh pasiennya, sehingga pasien itu menabrak-nabrak dan akhirnya menyadari bahwa dia adalah penglihatannya semakin tidak baik dan seringkali hanya terjadi pada satu mata. Jadi pasien itu sungguh-sungguh tidak menyadari dan ketika dia menutup matanya satu mata tersebut, baru dia menyadari bahwa mata satunya itu sudah tidak melihat lagi. Oleh karena itu pentingnya mengecek mata kepada dokter apabila seseorang mempunyai riwayat keluarga glaukoma atau misalkan pada usia lanjut ataupun punya komorbid mata pada usia di atas 40 tahun untuk melihat keadaan-keadaan yang kemungkinan terjadinya glaukoma yang kita tidak ketahui. Apalagi yang dapat kita lakukan pada dokter mata yaitu mengukur tekanan bola mata dengan menggunakan tonometri siot. Walaupun sebagai dokter spesialis mata kita tidak lagi menggunakan tonometri siot, tapi tonometri siot ini disediakan di puskesmas maupun di rumah sakit sekunder karena tentunya tonometri aplanasi Goldman itu tidak disediakan di pelayanan primer ataupun tidak semua rumah sakit sekunder mempunyai tonometri aplanasi Goldman. Nah, ini sangat mudah untuk melakukan tindakan tonometri siot. Teman-teman saya harapkan mampu untuk melakukan tindakan tonometri siot apabila dengan beban 7 dan didapatkan kita tentunya melakukan kalibrasi dan melakukan misalkan setelah mendapatkan dengan beban 7 dan didapatkan angka 25 mm AG, tentunya kita curiga untuk terjadinya adanya glaukoma. Selain itu, apabila pasiennya memang sudah terantuk-antuk ataupun terjadi jalannya misalnya menabrak-nabrak, ataupun kita ada kecurigaan terjadinya glaukoma, kita dapat melakukan suatu tes konfrontasi untuk mengukur luas pandang pasien seseorang. Tentunya hal ini memerlukan suatu pelatihan, tapi dalam hal saat lulus dari dokter umum, tentunya teman-teman sudah harus menguasai tes konfrontasi. Nah, hal yang sangat penting dan sangat akurat untuk melakukan pengukuran lapang pandang ini tentunya dapat dilakukan dengan perimeter komputer. Namanya ya ada yang namanya perimeter Humphrey ataupun octopus. Kita akan mendapatkan yang lebih akurat lagi dalam mengukur lapang pandang ini. Tadi telah dipaparkan oleh Prof. Healey di situ gambar-gambar yang memperlihatkan gambar yang sangat gelap ya untuk lapang pandang tersebut. Itu adalah yang diukur dengan perimeter komputer tersebut. Dan ini adalah fundus normal, kita juga dapat diambil dengan alat yang disebut Funduscopy ya. Jadi sangat mudah, hanya dipotret saja kita dapat mendapatkan suatu gambaran foto fundus atau gambaran retina secara keseluruhan. Dan akan tampak di situ ini adalah optic nerve, ya, akan tampak di sini saraf mata tersebut, di sini adalah makula, kita hanya mengingatkan saja, ini adalah retina, dan ini adalah pembuluh darah retina tersebut. Ya, ini mata kanan, jadi ini adalah di bagian nasal, ini di bagian temporal, di mata kiri, ya juga sama, ini di bagian nasal, ini di bagian temporal. Ini hanya mengingatkan kembali, ini adalah funduscopy. Oh, ini untuk lihat telinga ya. Jadi pasien itu duduk tegak, disejajarkan mata pasien dengan mata pemeriksa, pandangan pasien lurus ke depan. Bila memudahkan, diperlukan obat tetes mediatik atau sikloplegik yang digunakan dengan tetes tropikamid 0,5%. Itu akan memudahkan kita untuk melakukan pemeriksaan funduscopy tersebut. Nah, apa yang kita lihat, ini adalah pemeriksaan yang optik nerve mata normal. Ya, yang kita lihat adalah fisiologi optiknya, bagaimana kapnya, ya, kapnya ini berarti ini normal, ini 2 ya, 0,2 dan ini adalah disnya. Jadi kita bandingkan antara kap dan dis, ya. Jadi kita bandingkan antara kap dan disnya, berapa jaraknya? Kira-kira 0,2 rasianya. Ini adalah yang normal. Jadi di sini kita lihat neuroretinal rimnya masih dalam keadaan sehat dan warna colornya juga masih dalam keadaan vital. Bagaimana pembuluh darahnya juga masih cukup banyak, arteri dan pembuluh darahnya, venanya ya masih besar-besar dan ini masih dalam keadaan yang cukup baik. Dan bagaimana keadaan optik nerve glaucomatosa? Ini adalah mata kiri, kita lihat keadaannya, CD rasionya bagaimana, ini adalah penggaungan dari CD rasionya. Kapnya di mana sudah tidak terlihat lagi karena sudah terjadi suatu bentuk yang mangkok ya. Karena kalau misalnya seperti batu yang karena tekanannya yang sangat tinggi, kemudian tertekan yang terus-menerus, akhirnya batu itu menjadi dekok, ya, menjadi dekok dan seperti bentuknya seperti mangkok dan itulah yang terjadi. Lamina kribosanya akan lemah dan akhirnya menggaung. Inilah yang terjadi pada optic nerve tersebut dan nasalisasi dari pembuluh darah tersebut. Tampak di sini nasalisasi dari pembuluh darah terdorong ke arah nasal. Dan terlihat juga saraf matanya menjadi pucat dan jumlah pembuluh darahnya juga berkurang. Jadi terlihat pembuluh darah yang kosong di sini. Nah, apabila kita bandingkan optic nerve yang normal dari disnya dan ini adalah yang mulai menggaung dan di sini adalah yang sudah sangat menggaung, gambar yang ketiga. Ya, jadi di sini adalah optic nerve glaucomatosa. Di sini biasanya pasien sudah jalannya terantuk-antuk ataupun sudah menabrak-nabrak. Pada keadaan yang mulai menggaung ini biasanya pasiennya belum merasakan apa-apa. Itulah yang dikatakan oleh pembicara sebelumnya bahwa pasien itu biasanya seringkali mengabaikan obat-obatan yang diberikan oleh dokternya. Artinya seringkali artinya pemberian obat yang harus 2-3 kali, tetapi dia hanya sekali, ataupun dia hari ini menggunakan atau baru besoknya menggunakan, dan artinya tidak komplain terhadap pemberian obat-obatan yang mengakibatkan penyakit glaukoma itu mengalami progresivitas. Nah, penelitian dari 2001 oleh Dr. Artini di Yogyakarta, pelatihan melakukan funduskopi ini yang terhadap para medis selama 2 minggu untuk menentukan CD rasio 0,5 memiliki sensitivitas 51,2% dan sensitivitas 88,3%. Jadi dokter umum ini memiliki kompetensi penuh 4A dalam melakukan pemeriksaan funduskopi dan pemaparan saat fase klinik juga mungkin teman-teman ingat ya selama lebih dari 2 minggu dalam masa pendidikan dokter umum ini. Dan saya mengingatkan bahwa screening glaukoma itu sebetulnya ada 2, yaitu universal dan opportunistik. Artinya pasien apabila dilakukan screening glaukoma universal ini, itu adalah screening glaukoma yang berbasis populasi, yaitu screening glaukoma mengundang semua orang di dalam satu kelompok untuk menghadiri pemeriksaan screening. Artinya, jadi pemeriksaan kesehatan secara berkala. Pada umumnya, yang diketemukan untuk penyakit glaukoma ini akan sangat sedikit berbeda dengan opportunistik, yaitu pasien yang merasa bahwa dia deteksinya khusus memang mempunyai riwayat kasus-kasus keluarga yang menderita glaukoma, akan mendapatkan jumlah kasus glaukoma yang jauh lebih banyak, dan kemudian pasien itu mendatangi ke tenaga profesional kesehatan mata atau medis dengan keluhan-keluhan yang sudah menjurus ke arah glaukoma. Mungkin ini saja. Kemudian juga ini adalah challenge kita yang sudah dipaparkan, di mana memang kita memiliki masalah kesehatan secara keseluruhan. Di BPJS ini memberi kesulitan dalam hal pasien-pasien itu harus berjenjang ketika seharusnya pasien itu segera berobat ke rumah sakit rujukan. Dia harus mengalami, misalnya gini, glaukoma akut, seharusnya segera ditangani ke rumah sakit sekunder atau tersier. Tetapi dia harus menuju ke puskesmas dahulu, kemudian ke sekunder, baru ditangani ke tersier. Sementara pasien itu harus dalam waktu 24 jam ditangani segera, sehingga terjadi keterlambatan dan terjadi kebutaan yang permanen. Nah, inilah masalah-masalah yang dialami oleh negara kita. Jadi seringkali juga kasus-kasus yang sulit datang ke primer dan akhirnya datang terlambat ke rumah sakit rujukan, dan manajemennya juga demikian, masih tertahan di rumah sakit sekunder, sebetulnya masih kita dapat tangani dengan segera gitu. Dan tentunya kami juga minta tolong kepada dokter-dokter semua yang berada di rumah sakit primer ini untuk dapat menemukan glaukoma dalam tahap dini. Apabila memang menemukan kasus ini dalam tahap dini, segera kirimlah ke rumah sakit yang memang dapat menangani glaukoma dengan benar dan tepat. Ini saja yang dapat saya berikan. Terima kasih. Saya kembalikan kepada Dr. Anissa. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih Prof. Ike atas pemaparannya. Untuk teman-teman sekalian, mungkin tadi sudah ada 2 pemaparan yang sangat menarik, dan juga tadi dari Prof. Ike merefresh sedikit mungkin bagi teman-teman mengenai apa yang mesti dilihat dari funduskopi bila kita ingin melakukan screening. Mungkin sebelum ke pertanyaan di kolom Q&A, saya mungkin ada sedikit pertanyaan. I have a few questions. First, probably Prof. Healey. And well, we all probably, if we're not an ophthalmologist, I mean, if we are a GP, funduscopy probably an intimidating physical examination that we have to do. Probably me as a GP years before, not very confident in performing funduscopy. Maybe you have a trick or you have a message and key points on what to look and what to see in, I believe GP doesn't require to look the whole funduscopy as we did as an ophthalmologist, but probably you can give a little insight on key terms of what to see in funduscopy, probably for general practitioners.
Okay, thank you, Anissa. So for all the doctors out there who are feeling a little intimidated by funduscopy, you are in good company, not just in the rest of Indonesia, but in the rest of the world. So we're just actually, we have a few papers in press at the moment looking at funduscopy, because what we found, we did a study just a couple of years ago in Australia and found that the most competent funduscopists were the medical students. And from there on, the loss of skills and the intimidation for two reasons. Firstly, the discomfort which any doctor has in doing something for which they're not well practiced, and also the discomfort a doctor has about making the wrong diagnosis leads not just GPs, but endocrinologists, emergency physicians, even some neurologists from not wanting to pick up an ophthalmoscope. So I think the first thing to say is the very obvious disease which you will detect if you pick up that funduscope far outweighs any concern about missing something subtle, right? Early glaucoma, early stage glaucoma is difficult to diagnose. And I'll look at a disc and I might miss something very subtle. So there's absolutely no issue or concern about you missing early glaucoma. As I said in my talk, what you're looking for is what Prof. Healey showed: severe cupping, gross abnormality. Think about what else you can see, which you're going to easily pick up: gross papilledema, a vein occlusion, proliferative diabetic retinopathy. Very, very obvious things. In fact, there was a study in the US of people presenting to emergency department with headache, none of whom had funduscopy, and of whom, a reasonable portion had papilledema. And those patients' lives were potentially put at risk because no one picked up the funduscope. So in terms of tips, look, as well as I do, if you don't practice it, you'll lose your skills. So practice the funduscopy, make sure the battery is charged, make sure the globe works, okay? Practice on your colleagues, on your children. There's a few things you have to do. You have to be able to look through the funduscope without getting instrument myopia, which mucks up your focus. You need to, what I teach the medical students is to stand back, put your hand on the patient's head on the side that you're going to observe, bring the funduscope to your eye and look for the red reflex. Once you find the red reflex and you look in the red reflex, you'll often see a little flash of red, which will be a blood vessel. Once you focus on that blood vessel, and you may need to dial the little dioptric adjustment there till you get it in focus, you can then move closer to the patient. And as you come in through the entrance pupil, the optical entrance pupil of the eye, you will see the retina in focus. The first point of call is always the optic disc, because that's where all the blood vessels come out. You're looking for, is it absolutely white? Is it completely cupped out so you can't see any rim at all? Is it grossly swollen? Is it hemorrhagic? Once you've done that, you've got all those vessels there. You follow each vessel out a little way and ask yourself, is there massive exudate throughout the retina? Are there large flame-shaped hemorrhage? And lastly, you come from the disc straight across to the macula. And usually the patient will let you know if you're at the macula. And you remember the macula is that area where you don't see anything. There's no vessels there, and you just see this shiny reflex. And if you see that, that's fine. Disc, vessels, macula normal, you can assume that patient doesn't have disease. Remember, this will also help you diagnose cataract and corneal disease, because you pick up the funduscope and you won't be able to see anything, right? And when I was working up in the Northern Territory with our Indigenous community, where I had a direct ophthalmoscope and an old coffee-stained Snellen chart from 1930, I had to use that direct ophthalmoscope to diagnose everything. And what I discovered was that it was very good at picking up something going on in the front of the eye. Many ophthalmoscopes, you can dial a light around to get a slit, and you can look at the front of the eye with a slit. But I misdiagnosed corneal and cataract diseases because they're very hard to distinguish. But from your point of view, you're not needing to do that. What you're needing to do is bring that ophthalmoscope up and realize there's some dense opacity in your patient whose vision you measured who's poor, and send that patient off to say, look, this patient's vision's down, there's some sort of opacity anteriorly, can you please examine the patient? So don't be shy and don't be ashamed, and don't think there's something that you're going to miss which may be to the detriment of the patient. Think of it like doing a blood pressure. You're not going to do the blood pressure because, well, maybe the patient hasn't rested long enough. Maybe they're anxious, so you'll get an artificially high blood pressure. There's much more to be gained by doing it than not doing it. So just start doing it and just make it part of your routine general examination. If you're in a community where there's not a large number of ophthalmologists or optometrists, a Snellen visual acuity. Easy to do, your nurse can do it. Just make it part of your routine. And as one of my mentors said to me when I asked him about some technique of examination, he said, examine the next 500 patients this way and then come back and ask me the question again. So examine your next 500 patients with a direct ophthalmoscope and then ask the question, and I think you will have already answered it.
Thank you very much for feeling a very right point for that, to encourage us to do more and having more confidence in doing it. Mungkin Prof Ika ada yang bisa ditambahkan, Prof, terkait mungkin bagaimana teman-teman GP mungkin tidak rutin ya melakukan funduskopi ya, Prof. Jadi kira-kira dari Prof Ika ada poin-poin yang penting yang perlu dilihat oleh teman-teman GP.
Iya, saya rasa ya. Terima kasih, Dr. Ica. Menurut saya itulah pentingnya, makanya tadi saya lakukan yang simpel saja gitu ya. Jadi artinya jangan takut melakukan funduskopi pada pasien-pasien terutama yang mempunyai penyakit hipertensi dan diabetes retinopati gitu. Karena banyak sekali penyakit diabetes retinopati, pasien dengan diabetes mellitus itu datang ke puskesmas. Dia tidak datang ke spesialis ya, karena mahal kan datang ke dokter spesialis. Jadi umumnya itu datang ke puskesmas. Namun tolong diperiksa fundusnya, hanya sebentar saja gitu. Jadi artinya jangan takutlah melakukan pemeriksaan funduskopi. Nah, apabila misalkan terlihat terjadinya perdarahan, kan kalau perdarahan tidak sulit ya untuk melakukan ataupun melihat ataupun menilai terjadi atau ada tidaknya perdarahan di retina gitu ya tentunya. Nah, untuk itu kita bisa refer itu segera ke dokter mata karena tindakan ini akan membantu pasien tersebut. Nah, apa yang akan dilakukan oleh dokter mata? Tentunya laser ya atau misalkan injection. Nah, mereka akan dibantu dengan BPJS juga gitu. Nah, dengan demikian mata pasien itu juga selamat, tidak akan terjadi kebutaan permanen. Akan terjadi kebutaan permanen pada pasien dengan diabetes retinopati Jadi tolong bantu pasien itu juga gitu. Jadi ada kerjasama antara dokter, ya, dokter mata ataupun dokter yang merawat pasien diabetes mellitus. It's very important gitu. Ya, it's work as a comprehensive treatment for diabetic mellitus patients all together. I think you're right, yeah, Prof. Healey. I think we have to work together for diabetic patients to see the fundus.
Yes, a comprehensive management probably for the patient is required, not only from us, the specialist, but also more importantly for the GP because they were the first line to discover probably the abnormalities in early stage. Saya akan beralih ke Q&A. Ini ada beberapa pertanyaan memang di Q&A. Mungkin ada yang bisa saya gabungkan pertanyaannya. Mungkin yang pertama, mungkin Prof. Ika bisa menjawab terlebih dahulu. Jadi pada pasien yang memang dengan riwayat mungkin bukan cuma DM dan hipertensi ya, tapi mungkin dengan faktor resiko dan komorbid, kira-kira kapan harus dilakukan screening, Prof? Mungkin bagi apa ya, dan mungkin faktor resiko apa saja yang perlu diketahui oleh teman-teman GP yang kita harus aware lebih, mungkin pasien-pasien mana yang kita harus lakukan screening lebih ketat mungkin.
Ya, baik. Terima kasih atas pertanyaannya. Pada pasien yang mempunyai faktor risiko, tentunya pada keluarga yang mempunyai riwayat glaukoma, itu nomor 1 ya. Kemudian usia di atas 40 tahun itu, dan terutama mungkin 60 tahun, karena pada umur 60 tahun banyak sekali pasien-pasien yang memiliki glaukoma dengan tensi normal ya. Jadi tekanan bola mata itu masih normal, tapi dia memiliki juga glaukoma, gitu ya. Seringkali saya menemukan pasien-pasien seperti itu, ya. Dan itu tolong sekali untuk dicek keadaan funduskopinya, ya, untuk dilihat optic nerve-nya. Dan kemudian juga jadi old people ya. Dan kemudian juga pasien diabetes mellitus, ya, seringkali memiliki pasien dengan glaukoma dan kemudian hipertensi atau kelainan jantung ya. Jadi ada kelainan dari pembuluh darah, itu seringkali terjadi hal itu. Miopia ya, kelainan hipermetrop itu seringkali juga terjadi hal seperti itu. Mungkin Prof. Healey, can you add more about the factors for the glaucoma?
And probably to add, how often should we do screening, and probably which group of people need more attention in performing screening, funduscopy screening, Professor Healey?
Okay. Glaucoma risk factors are a little complicated in that there are many, but fundamentally glaucoma is a genetic disease. And while we don't fully understand it, the best way to imagine it, it's probably a classic polygenic risk factor disease. So there are some very rare glaucomas that there is a dominant inheritance, but you can probably imagine that you might need 6 relatively common genes to get glaucoma. And in the average Indonesian, there may be between 2 and 4. So what that means is that you get glaucoma sporadically. However, there's a predominance within families, because if you have glaucoma and you have children, then you are going to pass on at least half of those glaucoma risk genes. So because of that, family history really is the most important risk factor. The problem is, of course, that you don't get a family history. You get recall of a family history. And of course, the problem with the disease of aging is that if people don't live that long, they're not going to have the history. So there's 2 problems that we found when we looked at this in the Blue Mountains Eye study. First of all, there was a missing history in anyone whose parents had died in their 50s or 60s, which is probably not that uncommon in Indonesia. Secondly, often it was a history of a different eye disease. So, you know, was it cataract? Was it glaucoma? I'm not sure. Mother had something. Thirdly, there was a very big difference in who knew the family history. So we found a prevalence of glaucoma in family history of glaucoma in 12% of women and 6% of men, but even in the same family. So what that meant was the men didn't know anything about their family history. So, you know, you need to think about who in your families in Indonesia are the keeper of the family information. Is it the husband or is it the wife, right? Is it the mother? And what I'd probably say is that, you know, when you see those people as your patient, don't just think about screening for one thing, but get as much family history detail as you can. So, you know, you may get blank stares when you say, is there a family history of glaucoma? I don't normally say that. I normally say that, I mean, I see a lot of patients in Western Sydney, a lot of immigrant patients, a lot of patients with very poor English. So I say things like, does anybody have trouble with their vision in your family? Did anyone lose their vision when they were old? Oh, yes, you know, auntie and uncle lost their vision, but they were old, they were 60. So, you know, in our village, you know, people just lost their vision, that was normal. So asking people, do they have a problem with their vision, or did anyone tell them they had a problem with their eyes, will get you to pick up a lot of the important stuff. Because the thing about glaucoma is that, you know, the really bad glaucoma often has a family history. And when, you know, an otherwise well patient whose pressure is slightly high and who nerve still looks normal tells me that, you know, 5 members of their family have gone blind, I worry a great deal. They're the ones where really sending someone off early for treatment can actually save them. The other big risk factors, of course, for glaucoma are the diseases that causes secondary glaucomas. So the really big ones for that are diabetes, of course. And of course, the glaucoma in diabetes is not just associated with the open angle glaucoma. So your standard open angle glaucoma is more frequent in people with diabetes. But of course, diabetes, you have those nasty secondary rubiotic glaucomas, which is part of that whole retinal ischemia, hemorrhagic presentation. The third really important group, and they're difficult to actually diagnose, is the primary angle closure. So remember, that's that form of glaucoma where the anterior segment of the eye is very small and the iris comes up and makes contact with the trabecular meshwork and blocks it. And most people with this disease, I know in medical school you would have learned that they present acutely with a very high pressure, a dilated pupil, poor vision, a red eye. And of course we see that. But what we've discovered in the epidemiology studies throughout Asia, and I'm sorry I can't give you the figures in Indonesia, I'm sure Prof Vicky can, most chronic angle closure glaucoma presents like an open angle glaucoma. It just gets slowly worse over time. The clue though might be somebody who has, who is very long-sighted. So somebody who's got very thick convex glasses, or similarly someone with a family history. Those cases are difficult to pick up, but I think probably that is where you'll get the biggest win from doing a comprehensive eye examination. There is a simple test called a Van Herrick test, where you use a slit to look at the side of the eye to gauge the depth of the anterior chamber. It's difficult to do with a direct ophthalmoscope, but you know, it's probably the best way we have of trying to pick up this disease. In terms of how frequently you need to do it, well, what we recommend in Australia is that if you have a family history of glaucoma, you should be examined every 2 years. Now, obviously, it depends on what resources you have. We have many, many optometrists in Australia. So, you know, we have 25 million people, we have 1,000 ophthalmologists, and we have 5,000 optometrists. So those people with a family history of glaucoma aren't coming to us every 2 years, they're going to their optometrist to get a routine check. I think, you know, 2 years is pretty reasonable. Think about diabetic retinopathy. You want to get an eye examination with a first diagnosis of non-insulin dependent diabetes, because you don't know how long they've had it. Insulin dependent diabetes, you know it's going to take a couple of years for it to develop. So you want to see them about every 2 years. And then depending on the findings, of course, once they've gone off and had their examination, if, for example, they've got nothing going on, they may not need to come back for 5 years. If there are certain signs that are concerning the referring doctor or optometrist, then they'll bring them back sooner. So I think from your point of view as GPs, you know, having that management plan, which lists the problems, history of diabetes, history of hypertension, history of, you know, glaucoma, history of cataract, will just prompt you when you're seeing that patient to, you know, probably every 2 years, just go through that list again and just go, right, let's just focus today's visit on the eyes. You know, let's make sure we measure that visual acuity at least once a year, that we pick up that direct ophthalmoscope, and every 1 or 2 years we have a look in and we make a note, and if something's changing, we send them off. That's probably the best way to do it. The other way, of course, which is actually very powerful and we forget about it, is to empower our patients to help us with this. So when you go to measure someone's vision with diabetes, they'll say, what are you doing, doc? No, I'm here to get my blood sugar checked. What do you do in my vision? You're going to say, well, you know, diabetes can cause blindness. It's very important. Oh, I didn't know that. Yeah, so, you know, make sure when you go home, you tell your family that, you know, this disease can cause blindness. We need eye checkups. And remember, if you start to have eye problems, you come back to see me. So that making eye examination part of it, even if what you're looking for, you know, you're not going to find very often, don't underestimate the power of just telling that patient the importance of eyes. By you examining their eyes, they're going to go home and go, you know, the doc says actually my eyes are important. We've got to think about this. And that message will get out to the community. And then what might happen, you might have a patient coming to you and going, doc, actually I came in because I'm having a bit of eye trouble and, you know, I've got diabetes, and I was talking to one of my friends and he said that, you know, diabetes can cause eye problems. So suddenly what happens is you're picking up disease earlier, you know, and that's what we're trying to do, right? It's easy to diagnose the neovascular glaucoma. The patient's blind already, but we can't fix that. We just want to pick that up 6 months before. So just making it part of the comprehensive examination, remembering it yourself, telling all the patients, ask every patient whether they've got a family history of eye disease. And if they say, I don't know, tell them to go home that night and ask everyone in their family, or at the next celebration, right? The next celebration when the family come together, say, listen, go and ask them all. Because you'd be amazed when you ask around, somebody might actually have an eye disease. And then what you're doing is that you're picking up the history of eye disease, you're getting the cousin who's got bad eyesight to go and see someone, and you're getting that word spread about the importance of knowing about eye disease. And you do that for diabetes, do that for any other chronic illness, and you'll be amazed how rich that family history will become. Because I'm sure at the moment, like many of us, it's no, I don't know, I don't know, I don't know. So it's not helpful.
Interesting point. So history taking, especially the family history, is a very important point in anamnese, probably the first time you met a patient. So family history is something that you really need to dig on.
Exactly. And it could be, it should be important. So often it's not. And we stop there, you know, we don't dig. But yeah, keep digging. If you think of it as a public health measure, the cheapest and most effective public health measure to diagnose chronic disease early is family history, right? So devote a little time, it'll pay big benefits.
Yes, couldn't agree more, Prof. So in the Q&A, probably relating to what Prof. Ike and also Prof. Healey mentioned earlier, there's a question here asking, if the GP already done the screening from the intraocular pressure and found probably eye limit intraocular pressure, so probably around 21, but no other symptoms. What should they do as a GP? Do they need to, you know, even from the funduscopy, it looks normal. Do they need to keep the patient, or do they need to refer it to ophthalmologist? Probably Prof. Iko, or want to go first answering the question, Prof?
Saya dulu kali ya. Kalau misalkan 21 ya, tekanan bola matanya, kan kita meragukan, apalagi dilakukan oleh GP ya, dan dilakukan dengan tonometri shot. Saya masih meragukan tekanannya tersebut. Jadi saya lebih baik, dan tidak ada family history, ya sebaiknya sih nggak usah ya. Tetapi apabila ada family history-nya dan kemudian ada comorbid, sebaiknya memang kita refer saja. Gitu. Saya sih itu kalau saya. Tetapi apabila dilakukan pemeriksaannya dengan tonometri aplanasi, gitu ya, dan memang dia mempunyai family history-nya, mungkin sebaiknya di refer.
So, Prof. Healey, you have a comment on that?
So, without being able to eavesdrop on what Prof. Iki says, because I can't speak for her sake, but what I think, well, let me say him, we'll see whether we agree. So, you know, the question is, it looks like I've found a risk factor for glaucoma.
Yeah, risk factor.
Or perhaps it's such early disease that I can't pick anything up. Yeah. But I'm confident of what I've done. So let's forget about measurement errors or you know, lack of ability. Let's say we've done a diligent examination. So how many people who have no other risk factors and have a pressure of 21 develop glaucoma? It's actually very small. Probably over the course of 5 or 10 years, it might be 1 or 2%. There was a big study which looked at people with pressures between 24 and 32. And over 5 years, about 5 to 10% developed glaucoma, and over 14 years, about 14 to 20% developed glaucoma. So that's over a long period of time. However, when you have that finding in the context of other risk factors, that changes everything. Okay, so remember your sort of Bayesian probabilities. If your prior probability is high, there's blindness in the family, you know, the patient's wearing these big, thick glasses, they're starting to develop cataract. And when you get cataract, the lens gets a bit thicker. And for example, you screened them 2 years ago and their pressure was 10. Suddenly that pressure of 21 is totally different. So as a completely isolated finding, its value is probably not very high. If you have the resources to get someone to check the patient, that's reasonable. You know, I see lots of patients in my clinic where an optometrist has measured a high pressure and has been concerned about the findings and sent them to me, and I've looked at them and I've thought they're normal, and I'll send them back. That's okay. But when that is part of a constellation of findings, and in particular, when there's a big difference between the two eyes, because usually it's like blood pressure, right? Some people have run blood pressure of 100 and they're perfectly well, they don't fall over. Other people seem to be running at 130 and they never seem to get into trouble. But, you know, if they were 120 on 80 last year and they're 140 on, you know, 95 this year, something's changing. So if the pressures in the two eyes are very different from each other, if they're more than about 3 or 4 millimeters difference, if there are other risk factors, I'd certainly get it checked out. If it's absolutely isolated and the patient's well and you're going to see them again, it's not unreasonable to recheck it, save some resources. But it's a difficult, you know, it's a dilemma for most of us.
Yeah. Okay. Well, sort of similar point of view. But we have a very interesting question here in the Q&A regarding, you know, we encourage our GPs to do funduscopy, but today is in the Corona probably year.
Yes.
Of course, it is a very dilemmatic condition for the medical students. And there's one question here from Muhammad Samil. He asks whether what steps should we take for funduscopy examination, especially in this pandemic era, as we have to do physical distancing and all. And do you have any comment on it? Probably, Prof.
Yeah, no, I do.
First?
That's very important. So, of the 5 doctors, the first 5 doctors in Wuhan who died from coronavirus, 3 of them were ophthalmologists and 2 were ENT surgeons. The ENT surgeons got it from doing nasal procedures, surgical procedures that created aerosols. The ophthalmologists got it from examining their patients. So the problem with ophthalmology is you do need to get close to the patients. So it's absolutely essential to have masks, obviously. It's absolutely essential to screen all your patients before they come into your clinic. I'm sure you do. We ring all our patients the day before, and if they have any symptoms at all of a viral infection, we defer their appointment for 2 weeks. And in our clinic, we maintain social distancing. We all wear masks all the time. In Australia, if you have any clinical interaction that comes closer than 1.5 meters, you need to wear a mask. For the slit lamp examination, we use Perspex barriers as a shield. One of the problems that we have is that if the mask doesn't fit very well and you cough enough, you can spread it. So look, having just urged you to do more fundoscopy, I would have to say that, if the coronavirus prevalence in your area is, significant or substantial, I think, it is wise to probably restrict your fundoscopy to those people who clearly need it. I think you can do visual acuities for everybody, but I think, there is a definite risk. And I think, you're going to have to weigh that risk, and your own personal safety against the interests of the patients. And I think it's not unreasonable if a patient, is otherwise.
Itu dan sebaiknya memang dihindari untuk dilakukan funduskopi sesuai dengan kaidah ataupun kriteria dari AAO ya. Jadi memang sudah kita buat dari Perdami bahwa untuk melakukan funduskopi itu tidak diperkenankan memang. Nah, inilah menjadi masalah sehingga untuk dokter mata memang kita melakukannya dengan yang non kontak lensa, ya kan, dengan slit lamp. Tetapi untuk dokter umum memang menjadi kendala untuk itu. Sementara untuk itu ya jangan dilakukan dahulu.
So general precautions is very important, and probably if it's not very probably emergency, we could postpone funduscopy examination for these days during the coronavirus. Probably this is gonna be our last question because we have limited time. It's almost 2 hours we having this series. So there's one question that I think probably quite important. So for more optimal probably management for patients, which one is more valuable as a screening tool? So whether it is funduscopy, tonometry, IOP screening, or whether it's perimetry or probably confrontation test if it's for the GP, or even ultrasonography, or even there's one participant asked about the role of central corneal thickness CCT. So which one of those, both professors think is the most important in order to do screening? Probably Prof. Healey, you want to answer this one first?
I would actually take one step back and say visual acuity is probably the most important thing for screening. If we look at those other things, you know, what we're identifying with tonometry is a risk factor. What we're identifying with funduscopy is pathology and damage. Therefore, until we've identified all that pathology, we shouldn't worry as much about the risk factors. So if you look in the back of the eye and you see advanced cupping in one eye, then what the pressure is probably doesn't matter that much because you know they need treatment. So I would always tend to look at the tests that will give you pathology. Now, a visual field test will identify pathology as well. However, a visual field test is difficult to administer. There's a great deal of patient variance. If you do visual field testing on the general population, which we did in our eye study, 23% of people will have an abnormality on their visual field test. Not because they have a pathology, but because it's a hard test to do. The other thing is that a visual field test will, I mean, look, as a glaucoma doctor, it's a great test. But again, when I sit back and look as an epidemiologist, I'm going to ask myself, what's the one thing that you can do that is quite reliable, quite sensitive, detects pathology and detects different pathologies that are important in eye disease? It's funduscopy. And as I said, with that direct ophthalmoscope and that little slit, you actually can look at the front of the eye as well as the back. So it's pretty hard to beat that device, which costs a couple of $100, really, when we compare to anything else. For ophthalmologists, the key technology is optical coherence tomography, you know, a form of spectral domain imaging, because what that does, that's basically like doing a CT scan through the retina. So that gives us huge amount of detail. So that's been the revolution for us, but you know, it's not necessary. I mean, you know, when it costs $500, all GPs can get them, and you can start scanning away. But at the moment, they're $250,000, not $250. The direct ophthalmoscope is $250, and it will pick up that bad disease. Remember, you know, what's out there right now. You know, of those patients you saw today, there's probably a fair bit of important eye disease that you missed because you didn't have a look. So don't worry too much about the normal patient with a pressure of 21. They're important to get, but let's get the patient about to go blind first, and let's work our way backwards, right? And as we get better at doing all these things, you know, it's like, you know, Prof. Vicky showed the pie chart, where 88% of the blindness is cataract. So obviously cataract is really important in Indonesia. And in terms of people going blind, it's more important than glaucoma. So we should, you know, the Department of Health should allocate resources to do cataract surgery in Indonesia, which it does. And the, you know, resources I have seen in Indonesia, even in the little outlying islands, for cataract surgery is fantastic. So, you know, the country has it in hand. Give time, you know, expand the ophthalmology population, and you'll solve the cataract problem. So then you think, right, now what's next? So those other important diseases that are coming, the diabetic diseases, the glaucoma diseases, they're what's next. And something that's really simple that picks up the bad disease is what we want first before we move on to the more subtle things. Again, the corollary of cataract is, you know, do you just want to measure everyone's vision and do the cataract if the vision's down one line? Or do you want to do the cataract of the man who walks in who's got a white cataract that you can see without even measuring the vision? So, you know, clearly that cataract needs to be done before somebody who's just got a little bit of blurriness in the vision.
Prof. Ika, you have another comment on that?
Sebenarnya saya juga setuju. I agree with Prof. Healey. Yeah. I think vision, is the most important thing to the cataract. Is still our first problems in Indonesia, ya. And also I think ini kita lihat dari refleks dengan center kita bisa melihat refleks pupil, ya. Dengan refleks pupil kita melihat kalau misalkan tidak ada refleks pupilnya, itu menunjukkan bahwa fungsi dari optic nerve itu tidak baik. Nah, ini memudahkan untuk dokter umum juga melihat bahwa optic nerve itu fungsinya tidak baik, sehingga akan juga lebih memudahkan melihatnya dan tidak usah dengan tes ada COVID dan sebagainya gitu ya. Jadi menurut saya memang kita melihat dari bagian depan dahulu gitu. Dan sementara funduskopi ini kan juga lebih sulit melihatnya, apalagi pasien itu lebih banyak katarak kan. Nah, dengan pupilnya mid dilatasi saja kita sudah menunjukkan bahwa ini kemungkinan katarak, glaukoma gitu. Jadi visusnya turun, terus kemudian pupilnya mid dilatasi, refleks pupilnya juga menurun. Nah, ini menunjukkan bahwa dia pasti kemungkinan besar tekanan bola matanya dia naik di situ. Nah, ini ada tanda-tanda menunjukkan bahwa ini adalah glaukoma.
Yeah, I couldn't agree more. A mass screening for probably for general practitioners in terms of probably ophthalmology diseases, rather than probably focusing on the posterior segment of the eye. Probably we should focus more on visual acuity, because, well, right now I think the visual acuity measurement is available widely in the internet. You can just print it out, or probably you can use your smartphone to use it as a probably Snellen chart, just the screening patients with probably diseases, well, simple as cataract. And also I agree with Prof. Ike, pupil reflex is also an important point in screening for patients with probably eye diseases. We could just use a simple flashlight, and probably we could see a lot, we could probably screen a lot of eye diseases in those patients. So because of time limitation, probably I would like to conclude today's webinar. We've heard two interesting topics and presentations from both professors, Prof. Healey and Prof. Ike. About the first one from Prof. Healey is about the importance of our paradigm, or our way to see chronic diseases. Not only we treat the acute symptoms, but also to look at the disease itself, the whole perspective of the disease itself. And what I picked up is most importantly for general practitioners and probably other health professionals is risk factors, especially family risk factors, family history of diseases. We should dig more because it might inform us more about the condition of the patients. And also as GP, we need to be, encouraged to do eye examination, not only the funduscopy, but also the visual acuity, because it gives us so many informations regarding the visual conditions of the patient. And from Prof. Ike presentations, what I picked up most importantly is to understand the pathogenesis of the glaucoma, and also to look the most simple things from the funduscopy. Just look at the optic nerve head, the center of the optic nerve head, and probably the cup disc is important to screen glaucoma if it's possible. But most of all, I think in this pandemic era, I would also remind all of our fellows GPs to please stay safe, and universal precautions is very important when we examine our patients. If it's not very emergency, probably we can delayed funduscopy examination and probably do visual acuity examination. That is, we do more physical distancing with our patients, and reduce our risk to be probably exposed to coronavirus. Prof. Healey and Prof. Ike, do you have any last words you want to present here?
I would say just one thing related to the talk I gave about communication. What I didn't say was that we and others are actually working on a smartphone funduscope. So our idea is we have a little attachment that goes on the camera of your smartphone. It costs 50 cents and you'll be able to hold it up to the eye. You'll be able to look at the back of the eye with a slightly wider field of view than a normal funduscope. But most importantly, you'll be able to press the camera button and take a photo and then text it off to Professor Ike, who will be able to give you an instant diagnosis. That's the sort of thing that, you know, is within reach for all of us, and, you know, expect to see these things in the coming years. So as useful as a funduscope is, as well, much as they talked about it, you know, in a couple of years' time, you might be doing this on your smartphone, which would allow you to examine the fundus and social distance at the same time.
Okay, wow, that's very interesting, and I really can't wait for it to go worldwide. Probably it will help a lot of probably country like ours. Yes, Prof. Ike, to, you know, because we have a very broad geographic outline in Indonesia, so I think that will help a lot people here. And yes, sorry to point out the very important point that Prof. Healey mentioned is about the communications to our patients. Prof. Ike, you want to add anything before we close this series?
Thank you for the information. I think, yeah. Thank you, Prof. It's nice to meet you.
Okay,
thank
so
you very much.
I would like to thank you, Prof. Healey and Prof. Ike, for your participation in this webinar series, because this is the last of our series for probably for 2020 series. We hope we have another opportunity to have another webinar series next year, and I hope this won't be our last collaborations between University Indonesia Hospital with Prof. Healey and also Prof. Ike. And I would like to thank all the participants for joining us in this webinar series. We have 9 series before, and you can still watch our previous series in our YouTube channel or on our websites. And again, I would like to thank both of you for participating with us. And I'm sorry to other participants that we could not answer each, because we have quite a lot of questions here in the Q&A, but we cannot answer every questions because the time limitation. And because it's already almost 2 hours, I would like to end this meeting. Thank you very much, everyone, for attending. And Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much.
Thank you, Prof. Healey, Prof. Ike. See you.
See you later.
Ya, saya juga ingin mengingatkan kepada para partisipan, jangan lupa untuk pertanyaan yang menarik, ada kesempatan untuk mendapatkan hadiah giveaway dari RSUI berupa voucher dari Prodia, dan jangan lupa untuk mengisi evaluasinya dengan link yang sudah tertera di layar untuk mendapatkan sertifikat. Terima kasih.